Good afternoon, everybody. It is 12:07, and the Governance Committee for the John Peter Smith Hospital Board Managers is now in session. Thank you all for being here. I'm first asked to request, are there any citizens wishing to speak with us? I see none. We'll move on. I now need approval of the June 27th meeting minutes. Those are in the portal and available. I did not see anything objectionable.
No. Move approval.
Dorothy, for the approval? All in favor? All right.
Who was your second?
Chairman Powell. As far as committee chair report, I don't have a whole lot to offer today, other than number one, to offer my apologies for not being here on the 27th. We're all here a bunch, right? We know that. And that particular day, my son had the opportunity to play in the Little League World Series. They actually won the championship during that day. So I was sad not to be here, but I was much more happy to be there. That was a good time. So, Chairman Powell, thank you for taking over for me at last minute.
Chair, I'll just say this. When you called me, you didn't sound too sad. I think my exact words were, you need to be with your son.
Yes, sir.
He wins the World Series, so congratulations.
Yeah, so I appreciate you taking over. There's another item, item number 4A. We're actually going to pull off the agenda and not discuss it this time. There were some simple changes that the chairman of the board, Mr. Powell, had asked us to look into. And as with any bureaucratic system of anything, everything has legs. And it appeared to cause a little too much heartburn. So we will pull that off the agenda at this time. And once the acclaimed executive committee perhaps has more time to look at it and make their necessary changes, we can add ours at that time as well.
Thank you, Mr. Chairman. Thank you, Chair.
All right, moving on. Number 5, we're ready for Ron, Michelle. It's showtime.
All right, good afternoon. At today's meeting, and for some of the new board members as well, every August at this meeting, this is our typical time to present for the upcoming year for fiscal 20, our work plans and what we plan to do as a governance division for fiscal 20. And so at this meeting, we're going to cover the compliance and the internal audit work plans, and talk about how we got to what we're going to focus on, and certainly answer any of your questions. But before we get to that, wanted to start with a couple of compliance headlines. Did you want to do introductions first, or want to do that later? Okay, all right. So, as I always tend to do, I point out a few noteworthy stories that are happening in the compliance arena in healthcare. The first one is related to a Texas physician, specifically a Dallas physician, who was indicted for paying. He was essentially the CEO of Pine Creek Medical Center, and as CEO, he had paid for advertising and billboard advertisements for some of the other physician owners for Pine Creek, which was a no-no. And the OIG investigated the medical practice, and he was fined individually $171,000 personally, and was put, I believe, on the excluded provider sanction screening as well. The second one relates to a $74 million settlement with Premera Blue Cross and Blue Shield, and this one is related to a cyber breach. We've talked about cyber breaches a fair amount here in recent meetings. This one was a phishing attack, which basically going into an email of one of the employees of Premera. They clicked on a link, they provided their credentials because it looked official, and then the hackers were able to exploit and get information for over a month without being detected. And the reason why Primera was hit with such a sizable penalty is that they had done an assessment similar to the assessments that we do, and the assessment warned them that they had vulnerabilities, and they didn't address those vulnerabilities in a timely fashion. And so the government felt that they were not acting in good faith and could have prevented some of the damages. And so the $74 million includes the $32 million of which would go towards the victims of the breach, as well as the remaining amount would be to help them improve their security posture. So I bring this one up for two reasons. One is that cyber is continuing to be an issue in healthcare, and two is for those of you that are in the Finance Committee earlier, as I mentioned on our cyber coverage, this is one of the reasons that we need to have a robust cyber coverage as well. So. And then the last one is also a phishing attack at Presbyterian Health. Now, it's not the Presbyterian here locally in the Dallas-Fort Worth area. This one is in New Mexico. Similarly, there was a ransomware attack where they used phishing to get credentials and actually put some of their computers inoperable for a ransom. And it impacted nearly 300,000 patients. An investigation was done. I don't believe, it doesn't say here whether they paid the ransom. You tend not to want to pay the ransom because you never know if that might encourage that behavior going forward. But they were able to get dates of birth and socials and some other sensitive information from that. And so, again, this is a continuing, ever-growing thing. And then I will say that as we did look at JPS's security posture, one of the things I'll make note of, I know David's around here somewhere, but we have a new Chief Information Security Officer, who I think I mentioned last time, Mike Russo, who works with our office as well and on our privacy side to kind of help proactively identify these potential vulnerabilities. And then our cyber carrier, Beasley, does a tabletop exercise with us every year to help us to go through potential scenarios that are applicable to JPS. So just as a update. So with that, unless there's any questions, I'll move on to the compliance work plan.
So before we get into how we generate the work plan, I wanted to give you a little background from the compliance and the internal audit perspective. Focusing on, they refresh on a monthly basis. And so we are consistently going out to their site to determine what are they looking at specifically, where are they seeing patterns. Sorry. And then I want to skip down to 6, 7, and 8, and I'm going to talk you through in the next couple of slides what those actually mean. I don't know, you probably heard of RAC. That's quite prevalent, but MAC, Pepper, and CERT, I'm not sure if you have, or TPEs. Okay, that's good. I'm seeing some shaking of the head. So I, too, felt the same way. And so on the next slide, what I'd like to do is just briefly take a moment, and I will tell you this is kind of an oversimplification of what this means, because you can't actually find this information anywhere. You have to dig for it.
Zim, this is the Aggie page. This is so you and I understand what's going on.
So, That's an inside joke, I have no idea what that was about. Okay.
Oh, Sharon's for sure. She gets it.
So as it relates to the federal side and CMS has what they call Center for Program Integrity, the CIP. And these six, I guess if you can call it, these six types of reviewers are looking at a little bit of different things, but they also advertise and they report to Congress on what they're looking for or on their websites. And so I'm going to just briefly run through these really quickly. They all do pre- and post-payment reviews of our EMRs. And this list does not include the investigative resources like the DOJ or the Attorney General. This is, again, just what the CIP program consists of, the Center for Program Integrity. So we have MACs. MACs actually review Part A and Part B. They're really the simplest ones. They're more educational in nature. The MACs actually generate what you call a cert. Certs are those random audits that they do. They're looking for outliers and certain types of behaviors that they might want to expand and have a TPE, what's called a TPE. A TPE is a targeted probe in education. That is a 3-round educational session where they might send us a letter and they say, hey, JPS, I see you're an outlier in this area. We'd like for you to send us your records. We're going to, target your review, and we're going to educate you as we go along. And they'll do that for 3 rounds. If we pass the 3 rounds, everything is fine, they move on. If we don't, and we don't learn from those types of mistakes, they'll refer us to either a MAC or a RAC. Now, RAC is the sort of the bad word in this case. A RAC has every incentive to discover errors because they are paid based upon a contingency fee. We do have Medicare and we have Medicaid RACs. Medicaid RACs right now are a lot more prevalent, we're seeing, than Medicare for sure here at JPS. The supplemental guys, I call these the catch-all because this is a competitive bidding process where they're looking for a contractor to help them be more efficient, but to also help CMS do any kind of other supplementary ideas and audits that they want them to do. So anything that doesn't fit in the other 5 categories, that's what those guys are for.
So we hire them?
We don't hire them, sir.
They're hired outside, but then for a specific purpose, but then go ahead and look at everything.
They're maybe
So-
hired by the Medicaid program.
They're hired by CMS, that's
CMS.
correct, and I'll explain that on the next slide. So the UPICs are a little bit unique because they not only look at Medicare, but they also look at Medicaid. And then the UPICs actually go wherever the fraud allegations take them. So the UPICs is something else, again, another separate category. And then finally, we have the quality improvement contractors. And those folks generate what's called a PEPR report. That's a quarterly report, and they keep a trend on any outliers by hospital location, so they compare us to other hospitals to see you're falling outside of either the norm, whether on the low side or the high side. And they are in place to basically monitor all the complaints from patients for patient safety, patient quality, and also EMTALA. So again, that's kind of a quick rundown of all the folks that we constantly keep our eye on. We constantly keep look at the mail to see we have letters from these folks. And the next slide kind of recaps what each of those do in terms of pre or post-payment reviews. You can see underneath the name of MAC, Novitas is currently the contractor. So, Mr. Fisher, you asked for number 4, the supplemental contractor is called Nordian. That Nordian was contracted with CMS to provide that supplemental service. And as you can see, every single one of them are subject to request a medical record review post-payment. And then finally at the bottom at the QICs, again, those folks don't necessarily review medical records, but of course, if it leads that way for patient complaints, EMTALA, or any kind of appeals, they're also going to request for medical record reviews. So in a nutshell, this is the environment, if you will, on the federal side, what we have to deal with in terms of coding, billing, and claims errors.
Yeah. And what,
I'm sorry?
they should, yeah.
Yeah, they're supposed to,
There's-
because they hand off to one another quite frequently.
But in practicality, I've seen instances where you could have a couple of these aides look at the same type of review, and it would appear as if they don't talk to one another, unfortunately. And we have to go through the explanation process. But as I said, the RAC, the Recovery Audit Contractors for both Medicare and Medicaid, are kind of the sharks of this group, and because they are paid on a contingency. And so once they see a vulnerability in our coding and billing, and to where they're getting recoveries, it is like blood in the water to them, and they will be more aggressive, so to speak. What?
They call you for.
That's right.
Right. Oh, no, patient complaints, is that just a patient complaints that's called into Medicare? Okay.
Yeah.
Yeah.
All right.
Okay?
And there will be an exam on this.
So that leads us to the reason why we put on the work plan what we do. And in this particular instance for compliance, I put the targeted area of. Now that you know what those acronyms stand for, there's a couple on there you may not know. OCR is on there, it's at the bottom, Office of Civil Rights, and HRSA, Health Resources Service Administration. But here is our proposed plan for compliance for 2020. All 9 of these will actually result in a report that comes to this committee, okay? The E&M level review, that is actually a carryover from 19. We are responsible for establishing our own E&M level guidelines and evaluation and management, sir. So it's outpatient and ED. So we are planning to do 3 separate reviews. We're going to take a wide look at the CHC, our community health outpatient, our ED, and then our PEC as well. So those will be 3 unique areas.
And I'll say before she goes on to the other, is that the government over time has gotten more sophisticated in what they've looked at. They actually hired data data statisticians and data scientists to actually mine publicly available data, the Medicare, Medicaid data, and they can see across the country, where the outliers are, and so that's why it's important for us to look at the PEPR reports. Even though it's a bit of a delay, once we see the PEPR reports, it's about a year lag or 2-year lag?
It's not that, I don't think it's that far.
Yeah, but it's a bit of a lag. It's not real time. And so from a compliance perspective, we have to proactively look at what they look at before we get the letter, because by the time in most cases we get the letter from one of these agencies, they already have a good idea that JPS is out of compliance, and so you're in a scramble mode, so to speak.
Yeah. Cardiac and pulmonary rehab, that actually was also on the 18 plan where they were probes. And so what we've decided to do this year is expand those to actual audits. We're going to take a deeper dive. We only did about 5 each, found some anomalies, and so we're going to expand those 2. Flu vaccines, that's actually was a subject of a cert. We actually had an outlier at JPS on the payment of flu vaccines, believe it or not. Although it's minor, it is going to be a probe for us. We certainly want to take a look at it because the MACs are looking at that, or because of the cert, it was an outlier. NICU, level of care, that's also a carryover from the 19 plan. That will be a co-sourced audit, basically essentially an outsourced audit altogether, because you really need to understand the appropriate level of care that's being billed through the review of the documentation of the medical record. And so that does require a specific skill set. Radiation oncology, HIPAA privacy and security, and business associate, those are just going to be follow-ups. As you can see, we have done audits in the past already. You might remember the HIPAA privacy and security was done by an outsourced company called DHG. That's right? Mm-hmm. DHG. And we reported those results. Business associate agreement is actually underway right now, so you have not heard that yet, but we anticipate corrective actions for next year. The 340B program, and I'm going to stop right here just a second. I want to introduce someone to you. She is in the audience. 340B is a beast in itself. We have, behind number 8, we have an incredible amount of audit plans that lead up to that program audit. And what we would like to do next year is to be able to present a full year's work of what that 340B program consists of at JPS and the compliance monitoring behind it. And we have Audrey Williams. Stand up, Audrey. Wave. She's a little nervous. Audrey is our duty expert on 340B. She is our compliance specialist for 340B programs. She actually did this at a hospital, Mississippi, I believe. And so she's been here a couple of years now, and so she does the ongoing monitoring of our 340B. And then the last item for compliance, as I mentioned,
Yes. Yeah, Audrey's been here a couple of years now, and does monitoring for us. And I will have stopped to mention that if you heard Michelle say duty expert, that's a military term, but I just
it's not.
But no, you'll see 340B activity here in compliance, but also in internal audit, given the significance of the program to JPS, and we'll get into that.
And that last item, compliance program effectiveness review. As I mentioned before on the slide earlier, that will be an outsourced, completely outsourced review where someone would take a relook, a refresh at the program. You might recall in 2014, there was some work done in that space, but a lot of things have changed. And every so often, we need to measure the effectiveness of the program. So anticipate, if you will, some interviews, some questions by this group of folks to interview you. A lot of our senior leadership will also take part, and that report will be coming to you by that outsourced provider, separate from compliance. Okay?
And I'll say two things on this. This is a leading practice to do a third-party review of your compliance program. It's kind of a scorecard of us, so that, and it keeps us honest in terms of what we're telling you, in terms of how the program is doing. It also serves as a purpose of mitigation, for risk mitigation, because both from an insurance standpoint, because our insurance provider for regulatory asked us for a compliance effectiveness review. So it's a having one, and obviously having one that says good things, it helps with your premium in that area. But also, if JPS were to ever be under investigation or review by DOJ or others, that would be a mitigating factor to say that we've demonstrated compliance and a compliant, effective program. So,
I got a quick comment. Now, we've seen many of these things are carryover from 19. This is follow-up from probes in 18, another carryover for 19. I just want to address publicly, because we've addressed it privately. How many people are in y'all's department that are working on these plans, these very detailed reports?
We have 5.5 FTEs dedicated to compliance, and we have 3.5 to internal audit. So internal audit does not cover this, but I consider myself that 0.5 because I'm split.
Yeah.
So
But fully staffed, and have you always been?
we are fully staffed.
You are now.
We are absolutely
we
fully
have not
staffed.
always been.
And have not always been. So I just wanted, I'm making that point just because this group does an incredible amount of detailed work, and they're not always the people that other departments want to see in their department. It is a very difficult job, and for the amount of work that they do and the detail and skill to which they do it is tremendous. So my hat's off to both of you.
No, I appreciate that. One of the things, as she goes on to this next slide, that is important when we talk about compliance effectiveness, is messaging and building relationships, to the point that you just raised, and that it's oftentimes people in this profession are really excited about finding things and showing and sharing what they found and that kind of thing, and it's not as always highly received. And so, part of our professional development is how to build relationships with organizations, because ultimately we're not the government. We're here to help and try to find and fix things before a third party comes and finds it. So,
Yeah, it's really important.
yeah.
The next slide is also part of the work plan for compliance, but it's really those program requirements that we just have to do. We can't get away from these. So I know last month, number 8, we talked a little bit about those monthly exclusion checks. You might recall all those vendors and how we have to run those reports. So that's just part of the process. So we wanted to list those here. So collectively, the 2 slides would represent the compliance work plan for 2020. And I think I can stop right there.
The only thing I'll say to close this out from a compliance perspective is these activities have always been done in compliance. We don't always present them to you, mainly because we're required to do these things, but these are hours of time and effort that we have our 5 folks working on throughout the year to maintain the effectiveness of the program. So,
Does anybody have any questions regarding the 20 compliance work plan? None. This is an item that will need approval from us. If we do this, this doesn't go to the full board if this is a joint meeting, does it? It's done?
It usually does.
It'll come back again? Okay.
consent.
Consent agenda.
Consent, okay. Well, I'm just wondering, because it's called as a joint board and managers meeting, kind of seems redundant, but, hey, whatever.
I think that,
It'll go up as a consent, as if it's approved in this round.
Okay.
We establish joints, because sometimes we have class like that, that has something quick.
right, sometimes, since the committee allows, or since the board allows more members to be here.
Okay.
We have to.
Here, I got one quick comment.
Sure.
The book that has all the acronyms and what, as part of my reading, pepper is not in the book.
That's in next year's version.
I can send you some material, Dr. Weber.
I honestly have asked Michelle to make sure that as many acronyms are defined on the page as humanly possible, because it's really hard to remember.
Mr. Chair, I make a motion to approve.
Got a motion
Unless Chuck wants to add a
of pepper.
but other than that,
We've got a motion approved from Mr. Powell. Is there a second? Who wants it? I'll give it to Mr. Bose. All in favor? Any opposed? Motion passes.
All right, thank you, appreciate it.
Internal audit.
Internal audit, so likewise, internal audit goes through a sort of a different risk assessment to develop their plan. They're not concerned about the OIG, okay? Internal audit is typically, I could use the word governed if I can, by the Institute of Internal Auditors. And you can see down at the very bottom, there's a quote there from the standards, that says the CAE, which is the Chief Audit Executive, must review and adjust the plan in response to changes to business risks. Essentially, so what this is also saying is if we could be a little bit more dynamic and agile with the plan as risks change, then we will bring those changes to you as a board and say, hey, we maybe substitute this audit or two for something else. So a couple of things I just want to highlight on this slide. One of the things we did differently this year was item number 2 is review peer healthcare institution audit plans and reports that are publicly available. So we spent a lot of time in Parkland and a lot of the UT systems, UT Southwestern in San Antonio, El Paso, and MD Anderson. We looked at those reports to kind of see where have we not looked that they have, and we might be interested to find a few things. And then the last, yes, sir.
What do you mean you're publicly available? If I wanted to look one up, how would I do that?
Go to their website. Typically, it'll take you, I was just on Parkland's just a couple of days ago and was re-looking at a few of the way they present their follow-up audits and things like that. So
But they post their audit
they
reports.
post it.
Do we do that as well?
I'm sorry?
We post ours?
I don't think we do currently, yeah. That's something we can think about doing, yeah.
I'm just
So,
curious.
yeah.
Do y'all have personal relationships with your peers in those other systems as well that kind of, I think that's a great collaboration.
We have once a year, there in September, it's coming up here real quick, it's actually in Nashville this year. The Association of Healthcare Internal Auditors is a separate organization. And it's much better, in my opinion, than the Institute of Internal Auditors, because that's all industries. When you can hone in into your profession, and what I learned really this year, I really was paying attention, they have revenue cycle tracks, compliance tracks. So this year, I'm planning to go and really focus on the compliance track of that. But that's where we make, bonds with our leaders and other facilities, certainly in Texas as
Yeah.
well.
And similarly, on the compliance side, as I've told many of you, I'm a part of the American Hospital Association Compliance Roundtable, and we do a collaboration similarly. But no, that's a good question. We can kind of understand kind of the reasons and wherefores around that. So,
But there's no requirement
no,
to,
yeah.
And then the last thing, number 8, I just want to hit on that. One of the things we do after every audit, internal audit does, is we literally have a future audit topic session and we keep that document open throughout the review period to list and itemize things that we may see during the course of our review that we can't get to at that time. It's scope limitation, time constraints, something has come up. And so we keep that list and we run through those every year at the risk assessment planning time to see, you know, what did we not do last year that maybe we should focus on this year. So before I start talking through this work plan, who I would like to introduce next is the Director of Internal Audit, who really focused on this heavily and helped me put this together. And his name is Tim Lacusa. He has been here since
April of 2018.
Oh, okay, already.
You made it.
Yeah. He passed my, the duty. He's filling the duty, or the billet very well. I'm not easy to please, that's for sure. Tim actually has a lot of experience. He has experience with Baylor and UT Southwestern as audit as well, so he brings a wealth of information.
Thanks, Tim.
Yeah.
Thank you.
So one of the things that is of the AHIA, I just mentioned to you, the Healthcare Internal Audit Association, everybody's talking about biomedical inventories and the security risk behind that. It seems like, you know, it's the Internet of Things. It's, you know, I guess I read just recently that a patient will encounter an average of 10 medical devices per visit. And these medical devices are connected to other medical devices, internet, sometimes cell phones. I mean, so there's a lot of risk in that space. And so that's why it is on the plan for next year. You'll notice too that different from compliance, we are linking our top risks to the ERM risk, the enterprise risk that Ron handles with ERANA, because we want to link what we do in internal audit back to the significance projects that we have on the plate for leadership and the board. The second item is provider credentialing. That actually came from the UT system. Several of their folks did a provider credentialing review, and we had not done one before. The 340B drug program, here we go again. So this one is a completely independent and objective review that's going to dig really deep beyond what HRSA would do on a 340B audit. And the main reason is because we have brought online about 170 or so contract pharmacies since our HRSA audit. And so there's a lot more risk to us. So we felt it was really important to take a deep dive in with specialists into that space. Transitions of care. Yes, ma'am.
What does that look like when you're talking about a deep dive into the different companies and assessing them?
So a deeper dive would be how you come up with a report. So for example, the HRSA may come in and say, I want a download of the scripts that you filled last month. Well, a deeper dive is, how do we know that report is accurate and complete? What are the steps? Let me go through the steps to determine that you didn't omit anything. That's one of the example of a deeper dive. How we send out files specifically to our partners for our contract pharmacists. So we do send them our ADT files. We send them eScript files. How does that happen? Let's get behind the scenes on the IT side and determine, is there a way for this to be manipulated? So that type of stuff you don't see. A lot of governmental auditors don't dig that deep, but we want to know for sure all the ins and outs, you know, to have that reasonable assurance for ourselves. Does that answer your question? Transitions of care, that's a unique one, and we plan to co-source that one, of course, because we don't have a lot of skill set on the team for that. We have not yet decided, I know I talked to Tim about this, whether we're going to do transition from hospital to home, SNF, home health, hospice, whether we're, you know, from hospital external or within the hospital itself. So one of the things we do in internal audit is we do a mini risk assessment before we begin an audit. And so that helps us scope our audit a lot better. So we'll determine, sometimes we don't have all the answers when we present the plan until we get into it.
Audit the reauthorization of home health and all that stuff to cut down those spends.
So we haven't done that yet. So that would definitely be part of, you know, cost savings, cost avoidance, medical necessity. Is that the right level of care for the
Are you
patient?
talking about the referral process, and are we?
No, it's that's the number one game. A lot of people game the system,
Yeah.
and it's usually a mom and pop industry.
It
Yeah.
is.
A lot of PE firms start rolling them all into one, and then pop in the new software with sophisticated documentation. So they have template and they print really small font. So when you send 10 to 12 or 15 pages to the physician, they automatically will approve it. And anything over 2 pre-authorization is a red flag. And you'll be surprised to see 5 and 6.
Yeah, from the home health companies themselves, yeah.
Yeah, it's not fraud, because physician actually sign on
Has
to
to
it,
approve it, yeah.
but it's waste and abuse. So we may want to look at from a perspective of, because when you say fraud, waste and abuse, people are very guarded. But if you approach it from a low yield care, then all that stuff will pop up, and it's more an education also as well, to tell them that somebody's watching.
Yeah,
I've seen a lot of abuse, especially here in Texas.
yeah. Well, home health in general, as you pointed out, is ripe with abuse. So, yeah, we'll put that on the list for sure, yeah.
Contract financial tracking, that actually was something that our new Senior VP of Finance brought to our attention. She, you know, sort of requested that we take a look at that. Construction oversight. Now, this one, it's on the plan because we have plans to do an RFP to go forward throughout the stages of the construction. We expect that we would hopefully have a master service agreement with someone independent completely to protect JPS interests through all the construction phases. And so what we'd like to do is just co-source with someone, preferably outside the area, that may be, because, you know, a lot of times I think in the construction place, they all know each other, and so we really want some independence in that. And so what we'd like to be able to do is call you up and, you know, call up this co-source provider and say, I need you to come on site and take a look at this. And so it's just an open-ended, hopefully a master service agreement that we may have for about 3 to 5 years. But of course, that will come to you in finance for approval.
Yeah. And I will tell you, having done this at other places that had big projects, and having been a consultant myself, that oftentimes there's a confusion of what's the difference between this and, say, a construction department, that organization, like we have a construction and design department. And so, and it's not to say that we're doing anything that they wouldn't normally be doing. This is more of kind of helping them from what we call a project assurance standpoint, to ensure that all the controls are in place. We're not managing the project in any way. It's just more of ensuring that the controls are in place.
Okay. And then the last one on internal audit, much like compliance, the Institute of Internal Audit requires an assessment, a quality review assessment, externally every 5 years. So the review in 2014 really did not qualify as a quality assessment review, and so this will be a brand new one for internal audit. And again, much like the compliance one, you will be interviewed, you will have feedback, and the report will come to you by that particular co-source provider or outsource provider and give you the results of that. Okay. On the second page, this is all just follow-up of projects. So we have a requirement to follow up with any findings that we've had in the past, and so these are just very, just following through with that. We do have bolded ones on here that were on last year's, but we do expect 1 or 2 of those to fall off and need to be reviewed in 2020. Next month, what I would like to do is give you an update on this. We plan to do this semi-annually, give you an update on all follow-up projects, and I'm actually hoping that Tim could help with that on the next board meeting, I think in October, so he can help us with that. And then Tim has also created a new process to stay on top of this much better than I was, to be honest with you, helping these folks every quarter to provide a list of reminders. Hey, I need this project, where are you? And he has done a wonderful job of doing that. So if there are no questions on the internal audit project plan.
Michelle, this list is great, but it's also subject to change as well as different things pop up and as other priorities kind of sneak in as we have to adjust. Are there any other questions regarding the internal audit work plan for 2020? Need a motion to approve? Oh, go ahead, DT.
And the home health that he suggested on the follow-up.
So would you like us to do transitions of care to the,
Just-
from hospital to home health?
Just expand to look at the reauthorization. Those are millions
The
of
home
dollars
health
may escape
authorization.
our system. Those
I
are
guess, how big is that? I guess,
Yeah.
that may be
We-
something,
we
Michelle, we
could-
need to look at and assess
Yeah.
kind of a pre-work plan to figure out how big that's gonna be and if it's something that can fit in, because it is something very important,
Yeah, I've seen
especially on the fraud and abuse.
Yeah. Yeah, we can,
overuse.
we can come
Yeah,
back with a plan on that.
Yeah.
Yeah.
Absolutely.
Yeah.
And it could be that to Roger's point is that we maybe make some adjustments when we come back to, factor that in. And, yeah,
Because we're not sure if that's a transition of care area
Or a separate project.
or a separate project altogether, so,
It's probably social project.
Yeah.
There's a lot of
Yeah.
money
Yeah.
involved.
for sure.
Okay.
yeah, we can,
Okay, so you're looking for approval for their internal, for the internal audit plan?
Yes, ma'am.
Okay. Move approval.
Ms. DeBose with the motion, second? Dr. Weber with the second? All in favor? Any opposed? Motion passes.
thank you. The one thing before we go to closed session is, I'll say is that to Roger's point, and this is a positive thing, I'm going to put on position, that we have, over the past couple of years, gotten a fair amount of additional special projects, similar to the one that we discussed here today, by senior leadership, and to look at very special projects and advisory projects that don't necessarily result in a report that comes before this committee, but we provide a service to the operational side of the house. And so we're very appreciative of that, and I think that reflects some of the good relations that we developed, so.
Any other questions? All right, it's 12:50, and we will take, 12:49, we'll take about a 4 or 5 minute recess, move to executive session, and then come back.